Greetings everyone. On this episode we're going to talk about how to identify LVH on the ECG. Now, identifying LVH on the ECG is important. It's often misdiagnosed as a anteroseptal MI, so we're going to go over how it presents and why, and then that will hopefully kind of shed some light on why it is so misdiagnosed on the ECG. So LVH is a thickening of the left ventricle that predominantly occurs on the lateral wall. And anything that increases the pressure, the afterload on the left ventricle is going to increase that hypertrophy. So things like chronic hypertension, aortic valvular stenosis, prior MI, any of those things can cause the ventricle to stiffen as it gets thicker and thicker, and this can lead to diastolic heart failure. So that's another important key feature of LVH is that it's not an ejection fraction problem. It's not a problem of pumping blood. These patients develop heart failure due to an inability to fill due to that thick left ventricle. So to identify LVH on the ECG is actually pretty simple if you understand the basics of EKG interpretation. So the increased myocardial size, basically all the muscle cells, since there's more and more and more of them in LVH, they're going to increase the energy production on the left ventricle, and so you're going to see an increase in the QRS amplitude, the QRS amplitude height and width on all the leads that look at that left lateral wall. Those are going to be leads, all your lateral leads, so V5, V6, 1, and AVL. Also, because the ventricle is thicker, it takes longer to depolarize, so this is considered an abnormal depolarization, which is why you're going to note a wide QRS. And as if you've listened to any of my prior episodes, you'll have noted my comment that a fundamental rule of ECG interpretation is anytime you have an abnormal depolarization, you're predisposing that ECG to T-wave inversion. And so any wide QRS, you're often going to find flip T waves. That's a normal finding. It does not necessarily mean ischemia. And that's one of the reasons that LVH can sometimes get misdiagnosed. All right, so since in normal adults the left ventricle is electrically dominant, the QRS progression in the precordials is not significantly different. There is some slight differences, whereas where V3 and V4 are considered our transition leads, as they transition from negative to positive in the QRS, V3 is typically a deep S wave is noted there. But otherwise, your normal progression is noted. So V1 is negative, V6 is positive. Again, the only difference there is going to be the QRS amplitudes. V1 is going to be and V6 should have high amplitudes and should be very negative. There's technically millimeter criteria that you can use to determine LVH, but it's really unnecessary. If you see deep S waves in V1 with tall R waves in V6 and they're slightly wide with a couple other findings, it's probably LVH, especially if your patient has a medical history that corroborates that. So what to look for? Here's an animation, just kind of showing you what's going on. So V1 looks from the right ventricular viewpoint, V6 from the left, and so as you can see, since the left ventricle is growing and thicker, its energy production is going to skew the electrical vector towards V6 and away from V1, and so you end up with a down in QRS in V1 and upright in V6. They're both wide because it takes longer for the electricity to travel through the abnormally thick left ventricular wall. And again, as stated, anytime you have an abnormal dipole, you're going to have a flipped T wave. So you will see flipped T waves, downward T waves in V5, V6, 1, and AVL. Those are all the leads that look at that left lateral wall. Now, the key thing, the reason that it gets false diagnosed all the time is that we have got to get away from using ST elevation as our lone identifier of STEMIs. Okay, the problem is that any discordant ST elevation should provide caution in the provider before they activate. Anytime the QRS is down and the T wave is up, the T wave can and often will pull the ST segment with it. And what that means is that anytime you have a QRS that's down and a T wave that's up, especially in the presence of a wide QRS complex, that ST elevation that you can see can be normal and is not a STEMI. To qualify as STEMI, you have to apply the Scarbosa criteria, and so the ST elevation would have to be greater than 25% the depth of the QRS complex. So if you have a 20 millimeter deep S wave, you need 5 millimeters of ST elevation before it qualifies. And so, as you're going to see in a couple examples here, LVH, because V1, V2, and V3 are negative and wide, they end up with downward QRSs and upward T waves, and they have ST elevation in those leads. They're often false activated for an anteroseptal MI, and they are not. I'll give you some examples here. Okay, so as you can see here, if you're looking at this, you see ST elevation in V2, V3, and so you're seeing that, and then you see some ST depression in V6, and in the other lateral leads, and you might be thinking, oh, I've got a anteroseptal STEMI, especially if the patient was presenting with chest pain, which these patients clearly will because they have prior cardiac history often. This is normal. That ST elevation is normal. These QRS complexes are very deep, and that's clinically insignificant ST elevation. The 1 or more millimeters of ST elevation in any two leads is a terrible method for identifying STEMI. You're going to miss a lot of acute MIs using that, and you will falsely activate on a lot as well. Another key feature in LVH that I forgot to mention is because the LV is growing in that leftward angle from a vertical axis standpoint, you'll also have, typically, you don't have to, but you will often see a left axis deviation as well, which is present here. You can look and see that AVL is your most upright lead, which qualifies it for left axis deviation. Here's another example. Again, a lot of people are going to look at this and think this patient's having an acute MI. This is confirmed. This patient did not have an acute infarct. This was just their pre-existing LVH. They had a history of uncontrolled hypertension. And so you can see here you have deep S waves off the charts in V3 with the lateral T wave inversion and ST depression. V5, V6, 1 and AVL are all down. This patient was having significant hypertension at the time of the ECG, so there could be some potential ischemic changes, but this is not an acute infarct, and this is very close to the patient's baseline ECG. Another example, very ugly one here, surprises a lot of people. They would look at this and they see V2, V3, and they would think that we have a STEMI, but again, that ST elevation is clinically insignificant. You have very deep off the chart S waves in V2, V3, and then your QRS amplitudes and all the precordium is very high. You have the lateral T wave inversion. This patient's another example of a enlarged left ventricle. Another example, you can see the tall QRS amplitudes in V4, V5, V6. S waves aren't so deep in V1 and V2 and V3. But still meets criteria. The amplitudes are big enough. You have T-wave inversion in the lateral leads. You have a pathological left axis. AVL is the most upright. That is another example of LVH. So, final thoughts on this one. The key feature here is anytime you see deep S waves in the early precordial, so V1, V2, V3, with a little bit of ST elevation, take a second, make sure that it is a septal MI before we activate. Again, it's always best to err on the side of the patient, and so if you're unsure at all, you should always activate. But again, if your patient has uncontrolled hypertension or aortic stenosis as a history, and you're seeing a wide, deep S wave in V1, V2, and V3, with the opposite in V4, V5, or V6 with lateral T wave inversion, take a second, think about, is this LVH? And if it is LVH, or you know the patient has a pre-existing LVH, and you're trying to identify STEMI in those patients, that ST elevation needs to be at least 25% the depth of the QRS complex if you have a discordant T wave, meaning that the T wave is on the opposite side of the isoelectric line to the QRS complex. All right, I hope you found this helpful, and I'll see you on the next one.